All right, future nurse, let's talk a little bit more about the topic of medication administration because you're absolutely going to see this on your NCLEX. And if I was a student, these are the kinds of things that I would be focusing on when studying my pharmacology section. And bear with me because we're going to run through an example. So as I stated in my previous video, the NCSBN cares that you know why medications are given. Are you able to pick out red flags? Are you able to verify orders? Are you able to administer medication safely and prioritize the patient? I would start by sitting down, picking a drug or drug class, and running through these bullet points here. And let's do that with a commonly tested medication, which is Metoprolol. It belongs to the drug class of cardioselective beta blockers. Cardioselective means that it only works on beta 1 receptors, means that it's only working on the heart. Now, you might see metoprolol prescribed for things such as high blood pressure like hypertension, arrhythmias such as atrial fibrillation, angina, and other indications, but these are the top 3 ticket items. And how does metoprolol work? It lowers both your blood pressure and your heart rate. And if you're lowering the blood pressure and heart rate, prior to administering, you need to monitor the blood pressure and heart rate. And what would be some situations where you would hold this medication? If my heart rate is below 60, which is bradycardia. If my blood pressure is low, hypotension, let's say 90/60. Or if I have a heart block. Now, kind of very repetitive as you move down those bullet points, but it is really reinforcing that information. So if I'm lowering the blood pressure and heart rate, I may expect to see the patient has a lot of tiredness, but some adverse reactions that I don't want to be seeing is a persistent bradycardia, underlying arrhythmia like a bradyarrhythmia, a heart block, or exacerbations of other chronic diseases such as heart failure. Because if we decrease that blood pressure and heart rate, we might not be pumping as effectively as prior. Now, what are some interactions that I may come across if I have a client who is prescribed metoprolol? If that client is also diabetic, I want to be monitoring the glucose because metoprolol is known to mask hypoglycemia. If the patient has heart failure, then I want to be monitoring for symptoms of shortness of breath, edema, because these might be indications to hold. I snuck route into here. It's kind of important sometimes, but you just really need to briefly brush it over and know that metoprolol is typically given PO, but it can be seen IV. Just know it's not being given intramuscular subcutaneously. If you see that on a prescription, you question it. And lastly, what are some clinical pearls with education? We tell our clients don't stop it abruptly because it can cause rebound tachycardia. And we always educate on fall precautions because by dropping that blood pressure and heart rate, we can have orthostatic hypotension.